Hi everyone, this is Aditya coming to you with another sub-I lecture. Today we're going to be talking about fever, which is a very common topic for inpatient wards. So our learning objectives for today include looking at which localizing questions are going to be helpful in helping us figure out new onset of fever. We're going to look through some differentials of non-infectious causes of fever just to be complete. And then we're going to talk about the appropriate lab work and imaging and how that can help us evaluate our patients with fever. We're going to quickly touch on antibiotic coverage for different selected organisms. And finally, we're going to help you triage changes in fever in multiple patients so that you can manage your time more efficiently. So let's start with the patient. So we have a 65-year-old with a history of lung cancer on active chemo. She's coming in with a fever of 101.4, and that started earlier this afternoon. So why don't we take a second? Let's stop and think about what collateral information you might need from this patient. So pause the video for a second, take a couple minutes, and think about what you might want to ask this patient, what things you think are important going forward. All right, so the collateral information that we tend to get from patients with new fever, I think comes in two flavors. You want to get questions that you want answered by the patient, and those are kind of your source questions. Those are the ones that are going to help you understand what you need to do next. Then you're going to look at stability questions, and these pieces of information may be coming from other providers, such as your nurse. So in terms of our patient, we're going to be looking at source questions specifically by area. So that's how I really like to think about fever is, am I covering all my bases in terms of possible source? So am I making sure that this isn't a pneumonia, any shortness of breath, any difficulty breathing, mucus production? Is this something GI, nausea, vomiting, diarrhea? Is this something urinary? Do they have burning when they urinate? Is there an open rash or wound? Do they have any confusion? Is there neck stiffness, photophobia, phonophobia? And could this be something in the heart, a new murmur, or are there Janeway lesions on their exam? And then you want to contextualize your fevers. So looking at their vitals is super, super important. So not only are they febrile, but are they hypotensive? Are they tachycardic? Are they tachypnic? And are they dropping their O2 set? Basically, is this patient entering into sepsis? You always want to ask about your access because that may dictate what you do immediately going forward. Do they have old access, which may be a source of infection? And do they have sufficient access if you're concerned about sepsis and getting fluids in efficiently? And do they have respiratory support? Is their O2 requirement increasing? If this is a new patient to you, the nurse may have information on when culture data was last drawn. So maybe they just had blood cultures drawn 6 hours ago. You may not need to get new blood cultures at this point in time for a persistent fever. So let's walk through some scenarios. So scenario one, same patient. She has a productive cough. She's got some mucus, and her O2 sat is 93% on 2 liters. So what do you think is really going on here? We'll touch base on all of these in just a minute. Scenario two, her white count is down to 2. She's normally in a 4 to 5 range. She had chemo about 5 days ago. So what else could be going on here if that were the case for this patient? Scenario 3, she's confused. She has a white count of 19 and her UA is negative. And finally, scenario 4, she's got a hemoglobin of 6.5 and she just got a unit of packed red blood cells. So in our first scenario, we were obviously aiming towards a pneumonia. Because she's presenting from the community, it's probably a community-acquired pneumonia. This is important because some people may think, oh, cancer patients, they're in and out of hospitals. But really the guidelines about hospital-acquired pneumonia have really changed in recent times. And that's they have to have acquired a new fever, a new cough, a new pneumonia over the course of their hospital stay, not based on previous stays. And then scenario 2, so she's got some neutropenia and she had chemo. So any patient with active chemo, they may have a port, so you want to think about if there's a line infection. They also may be neutropenic from their chemotherapy. It's really important to be clear. This is not a patient that may likely be a neutropenic fever just quite yet. That you need to calculate an ANC and work through that, and that will determine whether you start this patient empirically on antibiotics. And then scenario 3, so we've got some neuro symptoms, some confusion, photophobia. She's got a white count, but her UA is negative. So less likely a UTI, and more likely I'm now concerned about meningitis, and I might think about LPing this patient. Scenario 4, she was dropping her hemoglobin. She got a unit of blood just now. You want to think about possible transfusion reaction, as this might also be something at play in this patient. So different ways to kind of think through information, but you can see how each of these pieces of information guide us a different way in terms of how we go forward thinking about a specific patient. That's why your localizing and source questions are so important when you're evaluating patients with fever. So infectious causes are pretty well reviewed, and you guys are probably pretty well versed on those things. But non-infectious etiologies may be a little bit more outside our wheelhouse. So you always want to think about drug fever. Is there something that we may have introduced into a patient's milieu that may be triggering a fever? Is this an autoimmune process that's taken off and we're just catching it now on the inpatient stay? Is this patient experiencing chest pain and might they be having an MI? Back in the day, people used to actually look out for MIs with fever curves, so you want to be sure that you're not missing something like that. Hence why your source questions are super important. Is this a occult DVT-PE that may be presenting with a new fever? So you always want to make sure you're examining patients and making sure you're not missing something like that. And like we just talked about, could this be something that we're also doing in terms of a transfusion reaction, either antibiotics or chemotherapy or blood products, things that might trigger a reaction that's not particularly infectious in nature? So, orders. What are we placing in for these people when we know that they have a fever? So obviously you want to check in on some laboratory data to confirm an infection and also help identify location of a potential infection. So your white count is going to be super helpful. The differential is also going to be super helpful. Maybe they don't have a true elevated white count, but they may have some bandemia that's brewing. Is this source in terms of the urine, the lungs? Is it a viral etiology in terms of an RPP? You also might think about grabbing blood cultures on someone that might look a little bit sicker, might have signs of systemic infection, especially when the source is not as clear as a urine or lung. Is this someone who's been on antibiotics and has had profuse watery diarrhea while they've been in the hospital? Is this someone you should be checking C. diff on? Or is this someone you're meeting from the ED, in which maybe a extended Kerry Blair might help identify a source of their diarrhea? Is this someone you need to lumbar puncture to rule out meningitis so that you can start them on the appropriate treatments? And for our cirrhotics, is this something in the ascites that you might need to tap? So always have your orders in mind along with your source questions in terms of how you evaluate patients with a new fever. So to quickly touch on antibiotics, I will readily admit to you I'm not an expert in antibiotics by any means, but I think this chart is super helpful in terms of identifying what you're actually covering for. So you have kind of more run-of-the-mill things covered by your penicillins and cephalosporins. You're worrying about your MRSAs and Enterococcus with your vancomycin. You're going to cover some of your Pseudomonas with the carbapenems and certainly with your cefepime and zosyn options. But also your fluoroquinolones can touch on some pseudomonal coverage as well. But the big thing to really take away from this slide is you always want to make sure what you're covering is represented by the antibiotic you then select. And there may be a little bit of confusion when you start to look at some gram-negative rod coverage, pseudomonal coverage, enterococcus coverage, anaerobic coverage. So you just want to make sure you're clarifying what you're actually covering and is the antibiotic you've chosen correct. So let's jump into some real life patients. Again, you're walking in the morning. You've got 5 patients with different hemodynamic parameters as well as vital signs. So let's walk through it. So we've got patient A coming in. They've got a temperature of 98 degrees, normotensive, normal heart rate, setting relatively well on 2 liters of O2, and their respiratory rate's a little bit elevated at 20. We got second patient, patient B, fever of 101.4, a little hypotensive, 90s over 70s, and tachycardic at a heart rate of 110. They've got decent SATs, 98% on room air, and they are not particularly tachypnic, respiratory rate of 16. Our third patient, afebrile, a little softer blood pressure, 100 over 60, normal heart rate, normal O2 sat, and normal respiratory rate. Fourth patient, fever of 102, wow, and a blood pressure of 140 over 80, so hypertensive. Their heart rates are fine at 80, satting well on room air, regular respiratory rate. And finally, our fifth patient, low-grade temperature, not a true fever, 99 degrees, normotensive, heart rate of 80, satting well on room air, respiratory rate of 14. So I'm not giving it any localizing signs or symptoms, but this is to help you think discreetly about how temperature is one metric, and you got to take it contextually. So your other vitals are going to help you kind of triage who to see first. So I would argue we should probably check in on patient B because I've got a couple of parameters that are out of whack, and I'm worried that this patient might be going into sepsis. So they're febrile. Similarly, patient D is also febrile, but I think the difference here is that this person is truly hypotensive. 90s over 70s are not particularly comfortable blood pressures. And they've got a little bit of a tachycardia to compensate. So you want to kind of drop eyes on this person because they look like they may be entering into sepsis. The discrete value of the fever may not necessarily be all that important unless it's super high. So, I would say a patient of a fever of 106 when just, a couple hours ago they were 98, that's someone you really want to check in on. But in this case, when you're splitting hairs like 101.4 over 102, then it's important for you to really take things in context. And also, these patients, hopefully, so you may know that someone has had persistent fevers, and this may just be more of the same. But now, as other hemodynamic parameters are changing, that maybe you need to spend a little bit more time and look in on this person. So that is it for a quick lecture on fever. Any questions, as always, feel free to email me. You can always page me. Good luck on the awards this month, and hopefully see you around.